sir. Good afternoon, sir. Rajesh, sir.
Hello, sir. கேக்குதா?
கேக்குது sir.
Good morning, sir.
Morning, sir.
சொல்லுங்க sir.
ஆடியோ வரல பாருங்க, ஆடியோ போட்டுக்கிட்டவா?
Iyer.
ஹலோ, அதுதான் இல்ல இல்ல.
ஹலோ,
இருக்கீங்களா? On behalf of SRM family, I welcome you all. I thank Dr. Rajesh for the
sir, audio off ஆயிடுச்சு.
Sir, we shall start the lecture, sir. More than 10 persons have joined.
Okay, sir.
We can start.
Start பண்ணட்டுமா sir?
Okay, sir. Start பண்ணலாம், sir.
Okay. Just how to take this?
Share screen.
Session பண்ணியாச்சு.
வருது.
தெரியுதா சார்?
வந்துச்சு சார்.
ஓகே. Good morning, everybody. Am I audible?
Yes, sir. You can proceed.
Okay, sir. At the outset, let me thank the Neurosciences Department SRM for conducting this discussion and class on EEG. So today's topic is on normal awake and sleep EEG in adults, slightly deviating from the program which was supposed to be normal awake and hype and activation procedures. So the next class will take activation procedures separately. So today we'll just go through the basic fundamentals and what all things you expect when you look at the normal awake and sleep EEG in adults. So it's restricted to the adult population. So in any adult EEG, when you are asked to take EEG, we have to have 20 minutes of awake and 20 minutes of sleep EEG. And any EEG which does not have a sleep EEG of at least 20 minutes is not very valid. We need to have 20 minutes of awake and 20 minutes of sleep EEG for us to have a proper interpretation of the EEG. Now, sleep EEG is very important for various reasons. One most important thing is there will be so many situations where the awake EEG will be normal and the sleep EEG is going to show abnormalities. For example, in any focal epilepsy, in many of these focal epilepsies, the awake EEG will be normal, but the sleep EEG will show plenty of spikes. So if you do only the awake, you are not going to pick up the abnormality. So we need to have the sleep EEG. So in a given EEG, you need to look into both the awake and the sleep component if it is a properly taken EEG. But in our setup, because of the various reasons, which includes the time constraints, as well as the patient probably struggling to get a proper sleep, we may not end up taking both awake and sleep. But you should take more efforts to get a sleep record also to complete a good EEG recording. Now, all the electrode placements and other details, Dinesh Naik sir would have dealt with in detail about the basic mechanism of taking EEGs and basic parameters one should adhere to while recording a EEG. So just going through it, just electrode placement. If you talk about the double banana, You have the midline FC, ZC, and PC midline electrodes, and two sets of parallel electrodes on either side, on the left and right, which will include the parasagittal group of electrodes as well as the temporal group of electrodes. So you can have changes either in the central leads or in the parasagittal leads. So when you have changes in the parasagittal montages, we call it a central abnormality or the centroparietal abnormality. Or when you have changes in the lateral most ones, which are just above the ear, that's a temporal chain. So we call it a temporal abnormality. So you can either have a parasagittal abnormality or a central abnormality or a temporal abnormality. So then again, the impedance, you all should know that. So we just give an external voltage, and then we measure the amount of current flowing in the circuit, which is formed by that particular lead. And the settings, which sir would have, Dinesh Naik sir would have dealt with in details. The usual setting sensitivity is when you 7 microvolts, when you give 1 millimeter displacement of the or 1 millimeter height of the discharge will be there. Filters are kept at 1 hertz to 70 hertz. That is the high frequency filter, or the low pass filter is usually kept at 70 hertz, and the low frequency is at 1 hertz. That means anything above 70 hertz will be filtered out, and anything below 1 hertz will be filtered out. And the impedance should be kept less than 5 kilo ohms, and the speed generally is around 30 millimeters, 3 centimeter per second, and usually we'll have something like a 10-second recording in each page. Notch filter is switched off, and calibration is using 50 microvolts. Now, my topic today is to take you through the normal EEG, an orderly visual analysis of the normal EEG, and what all you will see and how you will analyze. So before reading the EEG, as I mentioned, you should have both awake and sleep EEG in every EEG which you take. And before starting to interpret it, you should know the patient's age and state of the patient. If the patient was awake, the patient was sleeping, or the patient is in coma, patient is in ICU. All these situations you should know before you try to read the EEG. And the age is very important, because as the person grows up, the EEG changes will change. And the younger the patient, more precise the age should be, because the changes in the EEG, that's ontogenic development, happens very fast in the first few years of life, up to 12 or 15 years of age. And subsequently down the stream, you will have, for example, one is not very particular to know whether the patient is 80 years old or 60 years old, but you are very much enthusiastic, or you want to know whether the patient was 5 years old or 10 years old. It's going to make a lot of difference in the EEG, because by 10 years you should have a perfect alpha coming up in the majority of the EEG, but at 5 years you may not have, or even less than 3 years you may not have alpha in all the EEG record. So the lesser the age, more precise we want the age. And as I mentioned, the state of the patient, like patient is in in coma, in the ICU, or what is the state of consciousness of the patient is very important before you try and read the EEG. So in the normal assessment, what are the things which you're going to look into? One is the frequency, voltage, then the waveform, and the manner of occurrence, whether it is happening random, or you're getting a serial events, or you're getting continuous events. Then what is the locus? Where is the abnormality? What is the reactivity to various stimuli like eye opening, mental alerting, etc.? And what is happening between the two hemispheres? Are we getting a frequency of which is equal on both sides? Are we getting an voltage which is equal on both sides? Is there a suppression on one side? Is there an amplitude asymmetry on one side? And what is the synchrony? If events are happening on both sides, are they happening together? For example, synchrony, we talk about synchrony, we know the occurrence of sleep spindles. We expect it to be synchronously happening in a particular age of the child. Say, for example, after 3 months, you get synchronously occurring. That is, at the same time, occurring in both hemispheres. The spindles are synchronous above the age of 3 months. So sometimes, if you talk about biplets, and the plets, the biplets, sometimes in both hemispheres, the plets will be seen. And if it is not synchronous and it's happening at various points of time, it becomes bilateral independent plates. So synchrony means if it is happening almost simultaneously in the both hemispheres. These are all the things which are the important components of a normal EEG reading. So we look into the frequency of the waveforms, we look into the height, that's the voltage of the waveforms. We look into the type of waveforms we see, then we see whether it is happening in a continuous fashion or randomly occurring or serially occurring, and what is the focus of abnormality if it is there, and what is happening to the reactivity, and what is happening between the two hemispheres. These are the minimum things which one should look into when you try to read a EEG. So reporting the EEG, the completed EEG is reviewed by the neurologist who gives the final report is correlated with the clinical information. So going to the background activity, there will be one dominant frequency in the record. Not that, for example, if you talk about alpha, it may not be continuously seen throughout the record. There could be some situations where there can be less. It may not be the classical one, but in the throughout the record, if you look at the most prominent ones, that will be called the dominant frequency. And the dominant frequency will depend on the age of the patient and what state the patient is in. So the background activity is the usually we have the occipital alpha rhythm, which everybody knows, and that is the usual starting point of the visual analysis. So you're looking into the awake record, so you'll see whether the occipital alpha is there. So from there, your analysis will start. So take the EEG, see whether what is the condition of the patient. You know whether the patient is in coma or awake. What is the age of the patient, and of course, in some situations, it's a male or female, and after knowing all these things, you have to have an orderly analysis of 6 or 7 components which I mentioned. That is the amplitude, the frequency of discharges, whether the discharges are happening synchronously, what is happening between the two hemispheres. These are all the points which we will be discussing today. Now we all start, once we get the EEG in our hand, we start with the background activity of which the occipital alpha rhythm is the starting point. So alpha rhythm, as you all know, has a frequency of 8 to 13 hertz. It happens in wakefulness and doesn't happen in sleep. Maximum over the posterior head region, and amplitude is usually between 15 and 50 microvolts, and is best seen with eye closed, physical relaxation, and mental inactivity. So it's a situation of relaxed wakefulness. So you are awake, but you are relaxed. You are not thinking of anything. You are not calculating anything. If you calculate something, if you are too much involved in some other thoughts, the alpha won't be present. So the word for alpha is you are awake, but you are very relaxed. So the alpha rhythm must be restricted to rhythms which fulfill the above criteria which I mentioned, and because why you are telling this is you can have similar waves like which are called a mu rhythm. When you talk about the frequency, they are also having the same frequency, but I'll be showing you the mu where they are found and what is its reactivity is different. So to call something an alpha, it should be posteriorly placed. It should have a frequency of 8 to 13 hertz, and it will be reacting. It should occur in a state of relaxed wakefulness, and it should have a reactivity. So when this is not there, you should not call those waves as alpha. You might get waves of 8 to 13 hertz, which is not respecting what all rules which I mentioned now. Don't call them alpha. They are some other discharges. As you can see in the alpha reactive mouse. So if I show with the mouse, is it seen? The cursor is visible. Hello. Hello.
Audible, sir. Audible.
This cursor is visible. This I'm moving the cursor now.
It's visible, but you can make it full screen, sir. Only partial screen is getting open. You can
Okay. Full screen, yeah.
Yeah, you make it slideshow, it will come as a full screen. Yes, sir.
Is that okay?
Yes, sir. Yes, sir. No.
Okay, now I think the cursor is seen now. It is moving.
Yes, sir.
So you can see that the alpha, which I'm showing here now, is suddenly disappearing when the patient is opening his eyes. And once he closes the eyes here, you can see the alpha coming back. This is the normal reactivity of alpha. So alpha rhythm is blocked by attention, as I mentioned, visual stimuli. And if you put in some mental effort, an alpha rhythm has a slightly higher frequency in females, but the mean is around 10 hertz. The lower limit of the adult is usually reached by 3 years. By around 3 years, you should have alpha in some part of the record. But at 8 years, it will become the dominant rhythm. So alpha should be seen at some point of time by 3 years, and it will become the dominant rhythm by 8 years of age. So this is the classical beautiful alpha, which we demonstrate. This is the, as you can see, this is the beautiful alpha wave. You can see the alpha rhythm, which is spindle shaped, and you can see the rhythmic waveform of alpha. The incidence of alpha is less than 8 hertz is very less. I mean, you will not get alpha of less than 8 hertz, which happens in less than 1% of individuals. But above 80 years, you can have an alpha of say 8 or 7. It can still be normal. And it has got some relation with the cerebral perfusion. If you have a persistent ischemic state, you can have a lower frequency. And phenytoin toxicity is one, or any anti-seizure medication toxicity, especially phenytoin toxicity, will manifest as patient having a lower alpha. So in a patient who is on multiple anti-seizure medications, when you take the EEG, if you found the background is not reaching above 8, then think about the phenytoxicity or ASM toxicity. So amplitude, as I told, has got a lot of personal variation, and it will depend on the interelectrode distance. And if the interelectrode distance is very less, what will happen? The near discharges, the near potentials will be very equal, and the difference will be nullified. So the height of the discharge will be less. Higher the interelectrode distance, the higher will be the discharge, or the amplitude will be higher. So if you widen the interelectrode distance, then you are likely to get a higher amplitude, because the potential in this wider part are likely to be farther apart. So when you cancel out, when you A and B, when you minus the difference between the two will be of a higher amount, so the amplitude will be higher. But if you keep the interelectrode distance shorter, then you are likely to get a low amplitude discharge. And amplitude will always be high in referential than bipolar. This is also understandable, because in bipolar, the net effect of the nearby electrodes will only be coming, whereas in referential, the potential of the individual electrode in reference to any electrode based on the reference which you take, which is supposed to be close to 0. So the original amplitude of the discharge will be seen in a referential electrode. And then the alpha amplitude will be fluctuating from moment to moment, and you get the spindling. And you also see that when you have a faster alpha, for example, if it is more than 13 or 14, or I mean more than 10, 11, 12, close to 13, you will have a lower voltage of the alpha. So something like 9 to 11 versus 11 to 13. When it goes in the higher range of 11 to 13, you will have a lower voltage of alpha. This is another alpha which you can see here. As you can see, there is a waxing and waning. This is the waxing, and this is waning. Again waxing, again waning, and then again waxing. This is a classical feature of alpha. So beautifully demonstrated the alpha one, which keeps on waxing and waning phenomenon. Increases, then comes down, and again it increases, comes down. So it's a spindle-shaped discharge wave with waxing and waning phenomenon. Again, if you look at the referential, as I told you, this is the bipolar electrode. You can see the amplitude of alpha here. But if you look at the referential electrode, you can see that the amplitude is slightly higher than what you saw in the bipolar electrode. This is another evidence of the alpha, which is seen in the amplitude becomes much higher in as you can see here, in a referential electrode. So the amplitude is around 15 to 45 microvolts in 75% of adults, and in only around 6 to 7% it will be smaller than 15 microvolts. It's very rare that alpha is less than 7 microvolts. You can see this alpha discharge as again a beautiful demonstration of a kind of a spindling and waxing waning. Increasing is a beautiful demonstration of increasing, decreasing, increasing, decreasing, waxing, waning alpha. So it's the usual height. As you can see, 1 millimeter of the discharge is 7 microvolts. So this one will be something like 6 or 7 millimeters. So it will come to around 50 microvolts here. And the smaller ones will be around 1 or 2 millimeters, will be around 10 to 15. This one is 10 to 15 millimeters. So generally it is 15 to 50 will be the microvolts, the voltage height. So distribution is again the site of maximum alpha is in the occipital region, and less frequently you can get them in the central, temporal, or sometimes equal in all areas. And the occipital alpha will be attenuating on visual activation. Whereas if the alpha in some patients are more of parietal, rather than occipital, it can be parietal, or it can even be more anterior like centroparietal discharges. In those situations, you can see that the attenuation on visual activation, when you open the eyes, that is the visual activation, the occipital alpha immediately drops down in frequency and amplitude. But if the basic alpha of the patient is more anterior, it may respond more to some of the mental calculation or sensory activation like touching and moving the limbs and all. They can produce much more attenuation of the abnormality than the visual activation, because the alpha is predominantly posterior occipital. The visual attenuation is much more prominent in those patients or those people. I mean, 85% are having the occipital dominance, and they respond to visual activation. So this is again demonstrating the alpha here, and it will attenuate the alpha. It will attenuate the visual thing, and again picks up on closure of eyes. Again, this is alpha demonstration. The symmetry of the alpha asymmetry is noted in around 60% of the normal adults. So it's not going to be equal on both sides. The right side is going to be of higher amplitude normally. You know why? This is because of, generally in human beings, the left skull, the left side of the skull is thicker than the right. So what happens is that the filtering effect of the waves will be happening much more on the left than the right. So what happens here is that there is asymmetry of the amplitude happens in the with a lesser amplitude on the left, because the thicker bone will filter the waves on the left side. So asymmetry is because of the normal human asymmetry of the skull thickness, wherein the left is supposed to be thicker than the right. So this asymmetry, if you calculate by the height, in terms of the microvolts or millimeters, the difference is going to be less than 25%. Okay. So generally the right side is taller than the left for the reason which I mentioned above. So what happens is that to call something abnormal, there should be above 50% abnormal. If there is a difference of more than 50%, it is called abnormal. But if the difference is only 25% between the sides of right and left, wherein you find that the right is smaller than the left, then the difference need not be 50%. Even 25 to 30% itself, we can take it as abnormal, because normally itself the right has to be having a higher amplitude than the left. So any abnormality of more than 50% is definitely abnormal. But when you say that the right is higher amplitude than the left, if you can visualize here, especially between this and this, blue is right and the black is left. You can see that the right is slightly of higher amplitude, as you can see, especially here. Frequency. So we spoke about the asymmetry in voltage between the two sides. But what about the frequency? Frequency can be accepted up to 1 hertz. That is, if one side is 9, the other side can be 8, but not 7. So if the difference is more than 1 hertz, you have to call it of this central rhythm. It can be asymmetric. It can be present only on one side also. It may not be present on both sides. It comes in bursts and seen in central region. And asymmetry between the two sides is a rule rather than exception, and usually seen on both sides, but asymmetry. Now this is another important picture, just demonstrating the difference between the alpha and the mu in terms of reactivity at least. You can see the posterior P4O2, these are the P3O1, these are the alpha, whereas in the C3, we can see these rhythms which are going on are different from this rhythm. So, but the frequency wise, they may look similar. The frequency wise, they look similar, but what happens is that when you open when the eye movement happens, you can see that the eye opening happens, the alpha has attenuated, but the mu is persisting. So mu rhythm is supposed to be a representation of the sensory cortex, or the contralateral sensory motor area is supposed to be the substrate for the mu rhythm. So the mu will attenuate when the patient is moving the thumb, when there is a contralateral motor movement. So this is where he wiggles the thumbs, and you can see that the mu which is seen in F3, C3 and F4, C4 attenuates immediately. You can see this, whereas it persists when the person is opening the eyes. So it's a clear demonstration of mu and alpha, which are having similar frequency. But what happens is that when the eye opening happens, the alpha only attenuates, the mu persists, and the mu will disappear only with the contralateral limb movement. That's the wiggling of the thumb of the contralateral side, which causes a very beautiful demonstration of the basic difference between the alpha and mu. Okay, this is another demonstration of the alpha-like abnormality, which is seen in F3C3, but in P3O1 and T5O1, it's not seen. So this is an alpha-like problem in the central leads, which is the mu rhythm in this particular patient. Okay, is further demonstrations of the beta is another one where the frequency is more than 13, when the brain is aroused and active in mental activities and is seen in drowsiness and also in light sleep. So the beta, you can see here, beta is happening in various regions. So where exactly is it happening? It is predominantly happening in the anterior electrodes, whereas the posterior one shows only alpha. So it's more of an anterior demonstration of beta rhythm, faster rhythm inside here. You can see this rhythm is very fast. So the frequency bands can be common, which is 18 to 25, less common 14 to 16, and rare is 35 to 40. And for amplitude of beta, it is usually less than 20 microvolts, and if it is more than 25, it is regarded as abnormal. So in presence of defects of dura, there's a breach effect. If there's a defect of the dura scalp bone, the beta may be enhanced on the surface due to the low impedance caused by the breach activity. So brain as such will be firing in the beta range actually. And so if you are able to directly get the record from the brain, it will have more of a beta activity. So in breach, rhythm will have more of beta than alpha, because you are directly, almost directly getting things from the brain without the intervening bone. You can see this beta here, faster rhythm which is seen more anteriorly. Persistent asymmetry, first to show the diminished voltage in the presence of cortical injury or subdural epidural fluid collection. So when there is something which is intervening between the brain and the electrode, so when there is a subdural or epidural fluid collection, this asymmetry of beta is the first one to be showing there. Then the spatial distribution can be pre-central, as I showed in the previous ones. It's more anterior. Sometimes it can be posterior, or sometimes it can be generalized. So this is more of an anterior beta, which you saw, and then it can be sometimes pre-central. Yeah, it's more of pre-central, these regions, and sometimes it can be posterior dominant. Sometimes it can be generalized also, which is induced by benzodiazepines. This is a classical example of a generalized beta induced by benzodiazepines. Again, another example of a generalized beta. So in drowsiness and sleep, beta activity can appear at 18 to 25 hertz in the central and the post-central region, and amplitude increases in drowsiness and light sleep but decreases in deep sleep. Then the theta activity, frequency of 4 to 8 hertz, and waking theta is trace amount of 6 to 7 hertz, normally seen our frontal and frontocentral region. You should avoid mistaking the theta of drowsiness for the waking theta. So when you were drowsy, the theta starts appearing, but if the theta is seen in the awake period, it is usually abnormal. So you should differentiate between the two. So when the alpha has dropped out, then that will tell you that the patient is drowsy. And at that time, the theta appearing is acceptable. But the alpha is present normally, and then you see theta, then probably you are dealing with an abnormality. So that is how you have to judge whether the theta, because most of the sleep is going to be dominated by the theta rhythm, which is not abnormal. But the presence of theta in the awake stage is going to be abnormal in many situations. Other than, as I mentioned before, a trace amount of theta which can be present in the frontal and the frontocentral region. Then what are lambda waves? Lambda waves are biphasic, sometimes triphasic, sharp discharges. Where are they seen? Occipital region. When are they seen? When the eyes are open. Very important. When the eyes are open and you are exploring something with your eyes, that is the time when you see the lambda. So initially you'll get a surface positive phase followed by a surface negative phase, best seen in children of 2 to 15 years. So it will be locked to the saccadic eye movement. So this is a demonstration of the lambda where you can see the alpha here, the eyes are open. And this, we can see these waves. These are the waves of this is the best example. 1, 2. These are the lambda waves which are seen at the posterior region when the eyes are open and the person tries to do some visual visual scanning. You can see these waves coming up, first upward and then downward. This is the lambda waves which are happening on eyes open and the person tries to use his vision to scan the surroundings. Again, another example of the lambda waves which are seen in these. These are the lambda waves when the eyes are open, and you can see the eyelid fluttering movements when you're trying to scan a visual environment, which is demonstrated in this patient. So, and you can see the beautiful lambda. It's a good demonstration of the lambda waves happening. The moment the eyes are closed, the alpha comes in. See, the activities are appearing at the various stages as a person does various things. A beautiful demonstration of lambda activity. Okay, again lambda waves, as you can see, these are the lambda activity which is happening. Then the posterior slow waves of a youth are always mixed with alpha and seen in around young adults of 15 to 30 years, and generally between 15 to 20 years and rare after 21 years. So when you see the posterior slow waves, we can judge the age to be between 15 and 20. And it also blocks with eye opening and during drowsiness. It can be asymmetry between the sides and it not be synchronous also. So here this is the classical posterior slow wave of youth. It's a slow wave. It's a posterior slow wave. Immediately look at the age, it will be between 15 and 20. Posterior slow wave of youth. This is the posterior slow wave of youth. This is another one. So the posterior slow waves of youth will tell us that the patient's age is probably. So even the presence of the posterior slow waves, you'll be able to judge the age of the person. There's something called a phi rhythm also. It's the presence of 3 consecutive monomorphic synchronous slow waves from the occipitoparietal regions which are distinct from the background. It occurs within 2 seconds of eye closure on at least 2 occasions during EEG. Commonly occurs when alert and after the visual attention. And when you scan a picture or a pattern. And after HV also you can get this kind of a phi rhythm. So this is the phi rhythm which I mentioned. Phi rhythm. These are the 5 waves. So coming to the sleep part of it, generally the sleep waves are slower with the deeper stages of sleep. 5 distinct stages can be identified. First is the alpha dropout or the stage 1 which I mentioned. As you can see, the alpha is dropping down, is not having the 9 to 13 hertz frequency. It is of lesser frequency. This has dropped out very nicely. It's the alpha drop. Second is a light sleep where you get the symmetrical theta, vertex sharp transients and 14 hertz spindles. When you have the combination of vertex and 14 hertz spindles, we call it K complex. And the post, which are also very important thing to recognize, is the positive occipital sharp transients of sleep. So as you can see, the vertex waves start appearing. These are the post. They are positive means in an average montage, you can see them positive, that's going down. But if you see in a bipolar montage, it will be going up and you may think it's a spike. The moment you put it in average, it is a, because it's positive, it will be going down. So these are the post and then followed by the vertex waves. Vertex sharp transients, the focus lies at central CZ and it may feel maybe spreading to frontocentral or peripheral areas and usually bilateral synchronous and symmetrical, and it might be mistaken for a spike in children because many a times vertex can be very sharp also. And in raised ICP, what happens is that the synchrony can be broken. And normal children can have very high voltage also. This is the K complex where you have the vertex waves followed by the spindling effect. So this is the K complex which you see. So characteristics of stage 2 sleep is a spindle. It's again of 12 to 14 hertz. Appears as early as 6 weeks of age. So by 3 months you can see many synchronous spindles in the patient. So these are all the sleep spindles which you can see here. Some amount of difference in both sides is acceptable. In the K complex I mentioned, combination of the vertex wave and the spindle. It arises by around 5 months of age. So this is the you can see the spindle as well as the vertex waves. So you see this is the vertex wave, so this is the vertex wave alone. This is the vertex wave associated with the spindle. So vertex wave with the spindle. So it becomes the K complex. You can beautifully see the vertex wave followed by spindling. This is the best example. Best vertex followed by spindling is the K complex. Then post, as I mentioned, in a bipolar recording, it will be going up and it will resemble like a spike. But if you go to the average montage, you will see that they are positive, that is going down. The positive occipital sharp transients of sleep should not be mistaken for a spike. So these are the ones which are the post. As you can see, this is a bipolar recording that looks up and resembles a spike. I'm sorry, I'm not showing the average montage. It will immediately go down. This instead of going up, it will be going down in the average montage, as you saw 3-4 slides before. That will be the post. And slow wave sleep is not usually seen in normal EEG, and you will not reach that stage in the 20 minutes recording. Stage 3, if you get a good 10 minutes or 5 minutes recording of which shows the vertex waves and the K complexes, then that we can that is okay for a normal recording of the EEG. Then there's a stage 3 and stage 4 usually doesn't happen in a normal EEG recording. It happens only during the overnight or a video EEG recording. Okay. So I think I was able to complete within 1 hour, and thank you for the very patient listening.
Sir, thank you, Dr. Rajesh. It's a very nice presentation. Why do you bother about time, sir? If we have time, you can talk more. We don't mind. Thank you.
No,
Thank
sir.
you very much, sir. Anybody wants to ask any questions, you can ask either through chat or you can ask through your
Thank you,
audio.
sir. Thank you, sir.
If there is